whom will be presenting parts of this talk today. This project was conducted by a very multidisciplinary team, and in keeping with the theme of telemedicine and telehealth, this entire project, from its conception, data collection, analysis, and now as we look forward to writing it up for publication, was conducted via virtual platform. Starting from the top left of the screen, I'd like to introduce Dr. Leslie Eiland. She's an assistant professor in the Department of Internal Medicine, Division of Diabetes, Endocrine and Metabolic Diseases. She also serves as the medical director of the Endocrine Telehealth Program at UNMC and is a physician champion of telemedicine at Nebraska Medicine. Moving to the right, we have Jared Anzalone, who is our informatics specialist. Next, we have Dr. Anthony Donovan, who is a postdoctoral scholar at the College of Pharmacy. At the bottom left is myself. I'm an assistant professor in the Department of Neurology. I was with UNMC until June of this year, where we had established a large practice of epilepsy patients, telemedicine epilepsy for epilepsy patients. In July, I moved to OSHU in Portland, Oregon. So this project over the last few weeks has continued not only across Omaha, but actually across time zones. Next to my right, Dr. Carrie McAdam Marx, who is a professor in the Department of Pharmacy Practice and Sciences. She is an expert in the area of US healthcare policy and health services research programs and methodologies. And finally, Kaylee Sampson, who is our expert biostatistician and GIS specialist. This project was funded by the Great Plains IDEA CTR. We are thankful for their support and funding. We are also thankful for the support of UNMC's Clinical Research Analytics Environment, or CRANE, which served as the main data warehouse for this project. Over the course of this talk, we will discuss the status of telehealth used in Nebraska medicine during COVID-19 pandemic, specifically looking at geographic patterns of in-person face-to-face ambulatory visits and telehealth care. We will take a detailed look at telehealth's potential to address or exacerbate healthcare disparities, including demographics, rurality, median income, socioeconomic status, insurance status, etc. We will also be looking specifically at patients with diabetes and association of provider access with demographics and other socioeconomic factors. So, telehealth by definition is using electronic information and modern telecommunication technologies to provide patient care in a manner where the patient and the healthcare provider are not geographically in the same place at the same time. This includes both synchronous audiovisual format, for example, over digital formats such as Zoom, WebEx, etc., but it also includes telephone or audio-only visits by providers, which was something new during the pandemic. One of the main changes that allowed us to provide telehealth during the current pandemic were changes in reimbursement by CMS, which allowed the patient's home to be recognized as a place of service. Prior to the pandemic, CMS only reimbursed video visits when they occurred at a designated rural site. So prior to the COVID-19 pandemic, we were only able to provide telehealth care with ambulatory telehealth care where the patient was physically present at another rural clinic and the provider could be placed at a different hospital-based system. However, now we're able to do the same with the patient being comfortable in their own homes, thus mitigating the need for travel and possible spread of infection. This is a nice summary of ambulatory visits at UNMC from March 2019 to February 2021 of this year. In orange is shown the sum total of all visit types, including telehealth and traditional face-to-face ambulatory visits. The blue line, the blue teal line, shows just the face-to-face in-person ambulatory visits. The red line, which is kind of at the bottom of the page, you see shows the telehealth visits. You will note that in 2019, the total number of telehealth visits or telemedicine visits shown here in the red line were low because this was restricted to certain departments which had telemedicine capabilities. With rising number of COVID cases shown here in the dashed green line, in the early 2020, there was a substantial decline in face-to-face provider visits initially. This is the gap that you see between the orange and the blue line, with the blue line marking just the face-to-face ambulatory visits. Telehealth helped to bridge this gap, and you can see that by April 2020, we reached the peak of our telehealth visits, which was up to 30% of all visit types. However, by fall of 2020, things appeared to be improving to baseline, and currently telemedicine accounts from anywhere between 10 to 20% of all visit types. However, there is variability in different specialty types and service lines that are providing telemedicine. This chart shows that during the peak of telehealth visit, which occurred in April of 2020, family medicine, internal medicine, and psychiatry were some of the top users of telemedicine. Compared to them, telemedicine might be a little more difficulty for specialties that perform procedures and have other limitations, for example, the more surgical fields. One of our main goals, next slide, please. One of our main goals of this project was to study health disparities in telemedicine. A study conducted by the University of Pennsylvania system and they looked at patients from March through May of 2020, so the early phase of the COVID-19 pandemic, alluded to some of these possible inequities. In this study, they reviewed patients that were scheduled for both primary care and multiple subspecialty clinics, and they noted that older patients, Asian patients, non-English speaking patients had lower rates of telemedicine use. Not shown here, but when they compared video visits versus telephone only visits, they also noticed similar disparities, that some of these vulnerable populations were less likely to use the video format. In another study, and not shown here, but from University of Wisconsin, so in the Midwest region, which looked at older patients, which looked at all adult outpatient visits from June through August, so a little longer period, found again that older patients, rural status, lower socioeconomic status, Asian or African-American or Hispanic or Latino ethnicity were all associated with low rates of telemedicine use. However, some of the more newer studies that are coming out may suggest something different. A study from the Kaiser Permanente group, so a slightly different healthcare model in Southern California, where they looked at outpatient and telemedicine visits from January through October of 2020, and then compared it to corresponding timeline of 2019, found that in their population, Hispanic patients and low-income patients actually had the largest increase in telehealth utilization. They felt that telemedicine was potentially mitigating the impact of the pandemic in healthcare utilization for some of these vulnerable populations. So this raises the concern that could telehealth, the very tool that we're using to improve healthcare access, does it either widen or does it bridge these existing healthcare disparities? And this brings us to our research questions. We wanted to know whether patients who were already established at UNMC were more or less likely to have a visit during the COVID-19 pandemic compared to prior years. During the pandemic, given that telehealth was now an option, we wanted to know, were there any differences in the patients who did versus those who did not utilize telehealth during this pandemic, specifically looking at differences in demographic, rurality, socioeconomic status, health insurance status, etc. Next slide, please. We wanted to specifically look at patients with diabetes and study whether these patients who were already established at UNMC were more or less likely to have a visit during the COVID pandemic, and also study outcomes as measured by their hemoglobin A1C control and whether this changed between the year prior to the year of the pandemic. I will now hand off to Kaylee Sampson for the methods portion of the talk.
Thank you. So switching gears here to the methods, our study was a retrospective observational study looking at Nebraska medicine patients using their electronic health record data. Most of the data that we acquired, thanks to Jared Anzalone on our team, was de-identified and it was pulled from Crane. However, we also use zip codes, which are identifiable, considered identifiers, and those had to be arranged to be pulled from the EHR core, since that is the honest broker for our institution. So the inclusion criteria for our study is that the patients included had to have at least one ambulatory visit associated with a provider at Nebraska Medicine between March 16th of 2017 and March 15th of 2021. And we will get into the relevance of these dates in just a couple slides. The variables we collected included basic demographics like like age, sex, race, ethnicity, and as I mentioned, zip code. And then for any data that we didn't have at the patient level, we used American Community Survey census data as a proxy based on a patient zip code. So for example, the median income of a patient zip code and the percent of households with internet within a patient zip code were used as proxies for the patient's income and internet access. For clinical characteristics, we looked at if they had a visit associated with a diagnosis of diabetes, and for those patients, their A1C measurements. And finally, we looked at clinic visit characteristics, which included if it was in person versus telehealth, and also the insurance that they used for a visit. This next slide really gets into the meat of our design, and we were primarily interested in two main periods separated by March 16th, 2020. And this was kind of the first day that things really started to shift, especially in clinical care during the pandemic. And so we were interested in the 1 year period after the start date, and we call that the COVID period, as well as the 1 year period prior to that date, which we refer to as the pre-COVID period. And so this pre-COVID period kind of serves as a baseline or a control, in that had it not been for the pandemic, we would have assumed what happened during this time period should have looked a lot like what happened here. So this is kind of the function of the pre-COVID period. Going a little deeper into these timelines, for each period of interest, either pre-COVID or COVID, we looked back 2 years to see which patients were seen during what we call an establishment period. And so if a patient was seen in the 2 years prior to a period of interest, and then they were seen in one of either of these periods, they would be considered established. If a patient was not seen in the previous 2 years, maybe they were seen 5 years prior or never seen at Nebraska Medicine before, they would be counted as a new patient in this period. And similarly for the COVID period, its establishment period was the 2 years immediately prior to when the COVID period began. So as an example, if there was a patient that was, let's say, seen in early 2019, they would be considered seen in the establishment period. And if they were also seen in the pre-COVID period, they would be classified as an established patient. That same patient would also be in the establishment period for the COVID period. And so if they were seen between March 16th, 2020 and March 15th, 2021, they would be classified as an established patient. If there was a patient who was new in the pre-COVID period, they would be classified as new here. But for the COVID period, since they were seen during the establishment period, if they also came here, they would be considered established. So even though they were new here, if they came again, they would be considered established and not new for the COVID period. Similarly, we looked at if any of the patients seen in the establishment period had a visit, at least one visit associated with a diagnosis of diabetes, and that's how we defined our established patients who had diabetes. As you can imagine, many of these patients had multiple visits during either the establishment timeframe or the period of interest timeframe. And for those, we summarized each patient so they only had a single observation per timeframe. So when we go over our results, you might hear us say something like a patient had at least one telehealth visit, because they could have had 5, they could have had just 1, but each patient was only in the data set for a specific time frame one time. Characteristics for the patients were taken at their last visit in the established period. So this is especially relevant for things that might change from visit to visit, like insurance status. So we wanted to collect data as late in the establishment period as we could, so it would be the most relevant for the period of interest. And that way it was known, so this is all information that was known to be predictive of something happening in the future. We were unable to do this with new patients because we didn't have their information until they came during the period of interest. And so for those patients, we just used their data from the first visit they had in the period. As you can probably imagine, many patients were in both data sets, both established periods and sometimes both periods of interest. And thus, when we went to do the analyses, we couldn't treat it as though it's independent data because some patients had multiple observations, and we handled that in our statistical methodology. So for mutually exclusive group comparisons, and an example of this would be when we look just at the COVID period, and we wanted to look at patients who had at least one telehealth visit versus patients who didn't have any telehealth visits. We used chi-square independent sample t-tests, as well as logistic regressions when we built a model predicting whether or not a patient seen in the COVID period utilized telehealth, yes or no. For non-mutually exclusive group comparisons, an example of this would be when we were looking at all established patients, so all patients seen in either established period, and whether or not they had a visit in the adjacent period of interest. Was there a difference between COVID and pre-COVID time periods? And because patients could have both been in the COVID period and the pre-COVID period, that added some dependency to the data. And for that reason, when we were looking at one variable at the time, we would just use descriptive statistics. But when we went to do a model, we did a generalized estimating equation, which is very similar to a logistic regression, but it accounts for some of that dependency in the data. And then in addition to the statistics that we ran, we generated maps using data at the zip code level. So information was summarized within each zip code. And as an example, let's say we were looking at all patients for the COVID period, all patients that were seen in the COVID period's establishment period. So of all the patients that were seen 2 years prior to the COVID period, what percentage of them were seen in the COVID period? And these rates were calculated for each zip code, so it could have ranged from 0 to 100%. And then because we were having some issues with very small numbers, especially out in Western Nebraska or just further away from Nebraska medicine generally, we excluded any zip code that had less than 5, in this example, less than 5 patients seen in the establishment period in the denominator. We just didn't include the zip codes in that analysis or in the map. And then we aren't able to just map the zip codes as they are because zip codes are considered identifying. And so we utilized inverse distance weighted interpolation, which is a methodology to create a predictive surface using all of that zip code data. But if you look at any point in Nebraska, you cannot know, oh, at this zip code, this is exactly what the percentage was, because that interpolation method also factors into neighboring areas. And so it's kind of a good way to de-identify some of those smaller areas. And now I'm going to toss it over to Dr. McAdam Marx.
Great, thank you, Kaylee. So we'll go over the results first for the overall cohort of patients seen at Nebraska Medicine. And so our first research question was, we first wanted to establish if patients who were seen during the COVID period differed from those who were seen in the pre-COVID period, and kind of comparing COVID to that baseline period. And we did those for both established patients and new patients. So this gives us a description of the number of patients in each of these cohorts. So within the established patients outnumbered the new patients about 2 to 1. And for both of these two groups, you can tell that there were more patients with visits during the pre-COVID period than the COVID period for each of these groups. So this slide shows the patient characteristics for the pre-COVID and the COVID period for patients who were established. So these are the patients that had an office visit prior to an encounter prior to the time period of interest. First of all, you can see that they're very similar. Average age was around 50, about 60% were female. And about 70% lived within the Omaha metropolitan area, as defined as being within an urban zip code within 30 miles of the Nebraska Medicine Medical Center. These groups were not mutually exclusive, so we did not do statistical comparisons between them, but you can see that they're very similar. And there is a fair amount of overlap. About 45% of the patients, unique patients identified in the this overall established patient cohort group were in both time periods. Next slide. So this table presents the demographics of our new patients. So these are patients who are not seen prior to the period of interest. Again, as with the established patients, they're very similar. We could run statistical analysis on these groups. There were a few that were statistically significant, but given the very large sample size, even small differences were statistically significant. So, kind of need to then consider that some of these are statistically different, but not terribly meaningfully different. Comparing these to the established patients, just kind of numerically, we see that our new patients were somewhat younger, with an average age of 40 rather than 50, and about 55% female. We did see, however, that the difference, again, that most of these patients were close to UNMC in a zip code that was considered urban and within 30 miles, although that number was slightly less than what we saw with the established patients. Next slide. So this takes us to our next research question is, now that we understand that our cohorts of patients seen during COVID and the pre-COVID period were fairly similar, we then asked whether patients seen in the establishment period prior to COVID, if they were less likely to have an office visit than those patients who were established going into the pre-COVID period. And so obviously we could do this only in the established patients only.
All right, so here is an example of some of the maps that we made for this study. And on the left here, this is only for the pre-COVID period, and on the right, it's only for the COVID period. And what we're looking at is, out of all established patients, so all patients seen 2 years prior to the pre-COVID period, what proportion of them had a visit during the 1 year pre-COVID period, either in person or telehealth. We combined everyone. And what you can see here is the darker colors, or the more red, indicates a higher percentage of established patients who did have a visit during the period of interest. And you can see around the Omaha area and maybe Grand Island, it was around 50, 52%. And I do want to just make a quick note that these are rates. And so if we did count, this area would be significantly higher. But we're just saying, of all of the patients in the Omaha area, about 50% of them who were seen 2 years prior came in the pre-COVID year. And of the much smaller number of patients seen around Grand Island, of those, about 50% came during the pre-COVID period. And then around these areas, it's lower, and then it gets even lower out in the Panhandle, which is not a surprise given that there are other healthcare institutions and hospitals closer to this area than in Omaha. Switching over to the COVID period, when you look at, of the patients seen in the 2 years prior to COVID, what percentage of those had a visit during the COVID period, you can see that the overall pattern is essentially the same. It's just shifted downward. So there was just fewer visits, but it didn't really change the spatial distribution of where we're seeing patients utilizing in-person or telehealth visits during this time frame.
So when we conducted multivariable analysis to look at the likelihood of having an office visit during the COVID period relative to the pre-COVID period, we saw very similar findings to what we saw in the maps. And that was that patients were significantly less likely to have had an office visit during the COVID period than in the pre-COVID period. We then looked at other factors that were associated with having an office visit, and we see that there's certainly some things that mattered. Patients of older age were more likely to have an office visit, as are patients with diabetes. On the other hand, self-pay patients Asian and those of other race were less likely to have an office visit, as well as non-English speakers. And then finally, we also noted that those who lived further away, who were in a rural zip code or a zip code further than 30 miles away from UNMC, were less likely to have an office visit. Next slide. So this takes us to the next question. So if we're looking at patients, we wanted to know, did patients with a telehealth provider visit during COVID period differ from those with only in-person visits? And so we were able to do this for established patients and new patients as well. Next slide. So this slide just provides a breakdown of the visit types during the COVID period. We're looking at patients who had all in-person visits, patients who had all telehealth visits, and patients who had both. And the pre-COVID period is put here just for context and just to kind of reiterate what we saw in the earlier graph, which is essentially all of our encounters and office visits during the pre-COVID period were happening in person. And then but for the established patients, we saw that around 60% had all in-person visits, about 12% had all telehealth visits, and the remainder had both. When we look at the new patients, we saw, however, that more patients had all in-person visits, and that fewer patients had both in-person and telehealth visits. And so one thing to keep in mind is this doesn't take into account the number of visits that a patient had during the time period, so that the direct comparison between COVID and non-COVID should be done cautiously, or excuse me, between new and established patients should be done cautiously. For example, new patients may have been more likely to have multiple visits to have had both all person or telehealth. But it does sort of suggest that for new patients, there was a preference for being seen in person versus telehealth. Next slide.
So this slide, sorry, going back. We're playing around with control of the slide, so here we go. So this kind of shows similar information as what was in the previous slide, but just spatially. And as Dr. McAdam Marx mentioned, we didn't even bother looking with the pre-COVID period, especially with the maps, because there were so few patients who utilized telehealth. So here, these are only patients who were seen during the COVID period. And on the left here, we see established patients. So of established patients seen in the COVID period, what percentage of them had at least one telehealth visit? And what you can see is it's around maybe 42% in the Omaha area, and then it kind of increases as you get further out, but then maybe around Grand Island, Kearney, it's a little bit lower than that. And then as you continue out west, it increases again. I did want to make a note about this very obvious dark red area. This is likely an artifact of maybe just one or two zip codes who maybe only had 6 patients who were seen during the COVID period, and maybe all 6 of them ended up having at least one telehealth visit. And because a lot of the zip codes out in this area were excluded because of just way too small denominators, it puts more emphasis on the non-missing zip codes in the calculation of the predicted surface. So that's kind of what that is. Looking at just new patients who were seen during the COVID period, what percentage of them had at least one telehealth visit? The Omaha area tends to be the lowest, maybe around 25%, even though overall numbers is probably the highest when you look at the percentage of new patients in the Omaha area. Only about 25% had at least one telehealth visit. And then just generally, as you move west, this increases again with the same kind of artifact way out west.
Okay, so we then conducted a multivariable analysis again to look at what predicted patients having a telehealth visit during the COVID period. So this tells us the relationship between different patient characteristics and having a telehealth visit for established patients. And again, the purpose of this analysis is to help us to begin to understand whether the use of telehealth may be contributing to or helping to address any disparities of care that might exist. And so we see with this patient population, the established patients, that patients of older age, patients that were self-insured or have other forms of health insurance besides commercial Medicare or Medicaid, and select racial minorities, namely Black and Asian patients, as well as non-English speaking patients, were less likely to have a telehealth visit during the COVID period. We did see, however, that diabetes, for example, was a very strong predictor of having a telehealth visit. And then we got mixed results with rurality or distance and rural nature of zip codes that the patients lived in relative to the UNMC area and the Omaha metropolitan area. Internet use within the zip code and income in the zip code were each kind of modestly associated with telehealth visits in the established patients, with slightly higher likelihood of having a telehealth visit if internet use within that zip code was higher. Next slide, please. So this is the same sort of analysis for our new patients. So what predicted whether a new patient had a telehealth visit or not during the COVID period? And by and large, the results are fairly similar, with patients of older age and younger patients a little less likely to have a telehealth visit than patients in the reference group of 19 to 34. And otherwise, very similar trends with gender, insurance, and race and ethnicity. One of the things that we did find here that was different than with the established patients were that patients who lived further away from UNMC in a rural area or an urban area more than 30 miles away were significantly more likely to use telehealth or have a telehealth visit than those that were in the Omaha area close to UNMC. Next slide. And we'll turn it over to Dr. Eiland to discuss the results on the patients with diabetes.
Thanks, Carrie. All right, so on the next slide, looking at established patients with diabetes, and by diabetes, we're defining that as having a diagnosis of type 1 or type 2 diabetes in the problem list in our electronic health record. You will see that the established group in the COVID period is slightly larger than the established group in the pre-COVID period at just over 32,000 people. I don't think that's surprising that the number of people with diabetes is growing over time. On the next slide, so one of our questions was regarding people with diabetes seen in the established period. And we wanted to know, did patients with diabetes seen in the COVID period differ from those seen in the pre-COVID period? And you'll see that people with diabetes seen in the established period on the next slide. So looking at the pre-COVID versus COVID established period, meaning they had a relationship with a provider during the two establishment periods, there really was no major fundamental shift between the two groups in the two different time periods. They're very similar in age, race, gender, payer status, rurality, and have similar median incomes by zip code. And again, since these cohorts are not mutually exclusive, we can't make statistical comparisons. Our next question was, did access to care differ between the COVID and pre-COVID period for previously established patients with diabetes? And so here we see that between the two columns, the pre-COVID and the COVID year, so we're looking at the light blue boxes first. So this represents the percent of established people with diabetes who did not have any ambulatory visit during the year in question. And this was very similar between the two groups, just over 30%, slightly higher amount in the COVID year. But again, these two groups are not mutually exclusive. During the pre-COVID year, we see a very small percent of people with diabetes seen via telehealth, and that's mainly due to the challenges of reimbursement at the time. Those that were seen, that tiny little sliver, were having to travel to a rural community hospital to have a visit, probably with myself or one of my partners. But if you look at the COVID period on the right, of those patients who had at least one visit during the COVID year, about half of those patients with diabetes had at least one telehealth visit, which is noted in the darker teal box. Again, this doesn't mean that all visits were telehealth, but at least one visit was. So half of the patients with diabetes that had a visit in the COVID year had at least one telehealth visit. The next slide, moving on to the fourth spot. So this is showing the adjusted odds ratios of any visit during the study year in people with, during the study period in people with diabetes. And I think most important to note here in the red box is that adjusting for all variables below, people with diabetes were less likely to have a visit in the COVID period compared to the pre-COVID period. If you look at age, those patients less than 19 and greater than 80 were less likely to have a visit, with the group 50 to 64 being most likely to have a visit. Males were less likely to have a visit than females, and then people with lower socioeconomic status based on Medicaid or self-pay patients were less likely to have a visit. Race and ethnicity were not particularly influential, but preferred language was, and those with a preferred language other than English were less likely to have a visit. Looking at rurality, those that lived further from Omaha were less likely to have a visit compared to people living within 30 miles of our center. And lastly, income, which was based on the median income of a person's zip code, did not appear to be influential in terms of whether someone had a visit. On the next slide, our last question we hope to address was, did glycemic control differ between the COVID and pre-COVID period for established patients with diabetes? And this was based on standard quality metrics that we divided these into people who had any A1C less than 8, indicating pretty decent control, or greater than 9, indicating poor control. And so on the next slide, we see that there was a slight drop in the proportion of previously established patients with diabetes that had an A1C test in the year studied. However, really not nearly as much as we had feared. And again, these groups are not mutually exclusive, so we cannot assess p-values. Next slide shows the percent of patients in the pre-COVID year, which is in red, compared to the COVID year, which is the greenish color, who had at least one A1C greater than 9 on the left, less than 8 on the right. And as you can see, there's a very similar proportion in both groups when you compare the pre-COVID and the COVID years, which should really be a point of pride for our providers and clinics to serve people with diabetes that we were able to maintain during such a challenging year. So moving on to limitations, this was a retrospective study from a single academic health center. We only had access to our own internal data, not payer data. We also did not address or look at differences in specialty care. And we know that several divisions at Nebraska Medicine were able to immediately pivot and have high rates of telehealth that have persisted, like bariatrics and behavioral health. Whereas other divisions, primarily those that are more procedural in nature, have had very low uptake. We also did not study differences between telephone versus video visits, and we did not study direct patient outcomes. So in terms of conclusions, telehealth accounted for up to 30% of ambulatory care visits during the COVID period. And these highest rates were achieved primarily early on in the pandemic in the spring of 2020. We have found that patient demographics and geographics were similar between periods, but the proportion with a provider visit of any type was lower during the COVID period. Among new patients, telehealth was utilized actually more by people who did not live in Omaha, which is not surprising, and also from patients with zip codes, with lower median incomes. They had higher odds of utilizing telehealth for both new and established patients. On the next slide, characteristics associated with lower telehealth use included older age, uninsured status, minority race or ethnicity, and non-English speakers. And lastly, in terms of our diabetes-specific data, despite having lower odds of having a visit during the COVID period, established patients with diabetes who had an A1C collected at least once during the COVID period did not have a significantly higher odds of having an A1C over 9. So lastly, I think our data supports the fact that just simply recognizing home as a place of service and reimbursing for home-based video visits is not enough to address and improve these already existing disparities. And we really do need further studies and additional policies to address these health inequities that we are seeing regarding telehealth. We're happy to take any questions.
Do you want us to unmute and ask a question, or do you want it in the chat?
Unmuting and asking.
Oh, okay. Yeah, thank you. This has been really interesting and informative. So thank you all for presenting this. And I really like how you sort of explore this from so many different angles, and that geographic pace was that visual was really very helpful to see. I'm wondering with the analysis the findings you presented at the end related to diabetes, given some of the disparities that you saw in telehealth access, did you have enough of a sample to sort of look at whether there was any differences in A1C across people who were using telehealth and who weren't using telehealth, specific to where the disparities were occurring in telehealth use?
Dr. Eiland, do you want to take that one?
So am I understanding you right? You want to know more about specific A1C values and access and use of telehealth?
Yeah, so I'm wondering, so you were kind of showing that the A1C values weren't really different overall between telehealth users and non-telehealth users, but I'm also sort of wondering if there was, if you were able to kind of analyze that across some of the categories that you saw disparity use in telehealth.
I think that's an important question to address, but I don't think we have addressed that at this point or looked into that that closely with our data set.
Thank you.
Dr. Eiland, it looks like there's a question in the chat box for you.
Yeah, good question from Dr. Larson. So were we able to look at type 1 versus 2 diabetes patients in the cohort use of telehealth? We were not. We did not drill down that specifically to the specific diagnosis code. We just used diabetes, any code for diabetes in the problem list.
Hello, this is Nada Fadol here with the Specialty Care Center. So we looked at our patients who used telehealth during the COVID pandemic, and I'm talking about patients living with HIV in our clinic. And our primary goal was to look and see if outcomes change with the use of telehealth versus in person. And we found that actually people did well in terms of HIV outcomes, viral suppression, but we also had some selection bias because we only offered telehealth to patients who were likely going to do well. But in terms of implementation of telehealth and all of that, it kind of went smoothly and it led to what we expected in terms of the outcomes. But we're now looking in the stage where we're going to look at our data in more depth, and things that we're going to look at is inequities as well as distance safe to clinic, as well as other demographic variables. So we'll definitely be reaching out to you guys to see if we can get your help and collaborate on this data. But one thing I was going to mention is that our patients were primarily getting telephone visits, because from the beginning, when we looked at our patient utilization of one chart and videos and devices that are enabled technology, we have a severely underserved population and they didn't have access to that. So our one chart utilization was extremely low. So we just went with phone visits from the beginning. So do you have any idea what the percentage of patients that were getting phone visit was this, or was this only video telehealth that was included in this data?
My understanding is this was both audio and audiovisual. So phone visits and home video visits were both considered telehealth. Is that right, Kaylee?
That's correct. And we do have the numbers. I don't have them in front of me, but it was by far more video. The larger majority was video. And anybody else on the team, do you have it in front of you? Yeah, I want to say it was like 15% calls. That's just a guess.
Okay, thank you.
I do think that it would be really interesting to look at. I think similar to some of your questions about like show rates and compliance with visits, people who previously were not particularly compliant, maybe coming once a year, if that, for refills. Then once telehealth is an option, does their visit compliance increase? Does their frequency of visits increase because it's the access is improved or it's more convenient for them? I would love to do that from a diabetes standpoint as well.
Hi, this is Dr. Robin Lally in the College of Nursing. I took really good notes about the rurality and the use of telehealth, but I didn't get very good notes on the some of the social determinants of health that you covered at the end. And you said that non-English speaking and income and such were associated. Were they all negatively associated with use of telehealth, or was there some variation?
Anthony, can you go back to some of the forest plots? So for income, for example, we did see some difference between the models in terms of whether income was significant or not. And it was pretty modest in either case. So like, if you can kind of keep going up, and diabetes, it didn't matter at all. When we looked at the use of telehealth in new patients, there was, the higher the income, there was just a very modestly lower likelihood of using telehealth. And I think it was the same for established patients. If you go up one more slide, yeah, the same thing. So higher income was not necessarily associated with greater use, greater odds of having a telehealth visit. English speaking non-English speaking was very consistently associated with being less likely of having a telehealth visit.
Less telehealth, okay.
Yeah. And access to internet within the zip code was high in general, and I think it was associated with access to telehealth, but we're not sure really how to interpret that because it was so high. It doesn't tell us whether an individual actually had internet access. It just told us what the percentage of people in that zip code had internet access. So that would be something that we'd have to dive down into further to understand how access to broadband and internet affects telehealth use at the individual level.
It appears, if I'm looking at this correctly, that Black, Asian, and other also were on the less likely side.
Yeah, pretty typically, yes. Yeah. So it's like, and the overall patients were more likely to have an office visit in the COVID period if they were, or more likely to have an office visit if they were Black, controlling for all of the other factors. But when we looked at telehealth, they were less likely, as were Asian and others typically.
Okay, thank you so much.
I think there's a question in the chat. Is there any way to identify what type of device they connected with the telehealth? My understanding is, other than knowing whether it was video or telephone, we don't know any of that detail. And Kaylee, I don't know if you recall any further detail than that.
I believe it was based on visit type. So it was either like telehealth or home video visit. It was visit type in Epic, which doesn't differentiate with how somebody accessed the visit. So we don't know if they had a video visit that then failed and they had to convert to phone. We don't know if the video visit was occurring through the embedded Zoom link in Epic, if it was a separate Zoom link, if someone was using FaceTime or Skype early on. We aren't able to drill down to that level.
I'll add that sometimes with this, it's difficult because somebody could have a smartphone and you can access telehealth using Zoom on your smartphone, and not everybody has a laptop. So there are inherent disparities. And this again brings up the question I think Dr. McAdam Marx mentioned about broadband. So again, everybody seems to have a phone, but not everybody has a great plan where they're able to do video visits as conveniently as others.
There was a question about how we identified telehealth visits. And unfortunately, Jared was not able to be on the call today, but he did that within Crane. And I believe there was a field that was encounter type, and then it had various classifications, and we just pulled out the ones that were telehealth. But that's a great question for Jared.
If there aren't any other questions, and we would just like to thank our speakers, Drs. Datta, Sampson, McAdam, Marx, and Eiland, and the whole THINC team for presenting for us today. Take care.
Thank you for having us.
Thank you.
Thanks.
Have a good day.